Our final speaker tonight is Dr. Peggy Compton. Dr. Compton is an associate professor and Ameringin Endowed Chair in the Department of Family and Community Health at the University of Pennsylvania School of Nursing and a fellow of the American Academy of Nursing. Her areas of clinical expertise are opioids, addiction, and pain. She has published extensively in the scientific literature on substance abuse disorder in chronic pain patients on opioid therapy and the pain responses of opioid addicts with and without chronic pain. Having worked in several public treatment settings, she is an expert in the use of methadone, buprenorphine, and naltrexone in the treatment of opioid use disorder. She has served on FDA, SAMHSA, and NIH expert panels on prescription opioid abuse and contributed to position statements from the American Pain Society, College on Problems of Drug Dependence, and the American Society of Pain Management Nurses on pain management for patients with addictive disease. She currently serves as the principal investigator on a NIDA-supported grant exploring hyperalgesic responses in individuals undergoing opioid taper. The title of her talk today is Opioid Addiction: How Does It Affect Pain Systems? Please welcome Dr. Peggy Compton.
Thank you so much for that introduction, and thank you for the invitation to speak with you all about the work that I do. I'm going to be talking today specifically about opioid addiction. So we've heard about alcohol and cocaine, but now we're looking at another substance can be that people can become addicted to, have difficulty managing their use of. And I'm very interested in how it affects pain systems. And I start with the question of who cares, because for a long time we really didn't care about the pain that addicts were feeling. And so coming from a nursing background, let me just tell you a little story. I worked in methadone clinics for years, and I would work with patients who were working hard in treatment and really trying to get clean and really, doing what they needed to do. And they might develop a painful condition and have to go into the hospital and have their pain managed. Maybe a surgical procedure, or they had an infection or something where they had some real pain. And they would go into the hospital, and people would not believe their reports of pain. People would say, look, you're on 70 milligrams of methadone. That's a very strong opioid. You can't really be feeling any pain. You're just watching the clock, or you just want to get high. We don't believe your reports of pain. And as a nurse approaching those patients, nurses are forced with kind of looking at the complexity of a person. We can't just say, oh, I'm treating your addiction, I don't care about the pain, or oh, I'm treating your pain, I'm not going to worry about the addiction. We've got a person sitting in front of us who both has an opiate addiction and has pain. And so as a nurse, I had to care about what do we do with this patient who's on a large dose of opioids, methadone, for the management of their addiction, and they're saying they have pain. What's going on there? Now, we know that opioids, this is the poppy where opiates come from, that opiates are very powerful analgesics. They're probably the strongest analgesics that we have out there to really treat severe pain. But also we know that opioids can bring an intense euphoria, so that the opioids have both of these effects. And my question was, how do people who are doing opioids in an addictive way, or on something like methadone for the treatment of addiction, how does that affect pain systems? And at this point, when I went to the literature, there was a whole literature on opioids and how it's a good analgesic and how it manages pain, and there was a whole literature on opioid addiction and how opioids can result in addictive disorders. But nobody, these two literatures weren't speaking to one another. And again, I think a nursing clinician perspective is where I was forced to say, okay, let's bring these two fields together. How do we understand what's happening in the patient in front of me? And I think one thing that's kind of interesting about opioids is that it really, it plays on this continuum clearly of pain versus pleasure. And I'm not the first person to think about the fact that kind of these feelings exist on a continuum. You can see in antiquity that people were saying to Balzac, for pain is perhaps but a violent pleasure. Who could determine the point where pleasure becomes pain, where pain is still a pleasure? Chiron in the 1500s, pleasure and pain, though directly opposite, are yet so contrived by nature as to be constant companions, and it is a fact that the same motions of the muscles of the face that are employed for both laughing and crying. So this idea that both the reward, the euphoria that you can get from opioids, as well as the pain that can occur, exist on kind of a continuum. And the neurobiology, supports that. We know that opioid systems are involved in both neurologic pain responses, or the management of pain responses, as well as addiction responses. And we know that because we can block the effects of analgesic effects of opioids, and we can block the reinforcing or euphoric effects of opioids by administering an opioid antagonist like naloxone or Narcan, which is probably what you're hearing it called on the streets as we're administering it to people who have overdosed. So that we know these opioid systems are involved in both pain and pleasure. Also, that when opioids are given, we see the second messenger-induced changes that occur in neurons due to opioid exposure, which result in things like tolerance. So that people become tolerant to the analgesic effects of opioids over time. Addicts become tolerant to the euphorogenic effects of opioids over time. So that these opioids, again, work on these same neurons within these same systems. So I decided to go out there and measure pain in people who had opiate addiction and were on large doses of methadone. And this is actually my hand on the cover of Science. I was a cover girl once in my life doing a pain test. This is a simple cold pressor pain test, which is used commonly in human pain studies. Simply a glorified bucket of ice water, and you see how long you can keep your hand in the bucket of ice water. And when the cold first becomes painful, we call that pain perception. And when the pain becomes intolerable, we call that pain tolerance. And so I used a very simple sort of method to look at the pain responses of people who are on methadone to try and understand how does being an opiate addict, how being on methadone, how does it affect pain responses? And these are some data that came from that study. And what I was doing was comparing people who were currently using their substance of abuse, current opiate abusers and current cocaine abusers, and comparing them to people who were now in recovery, who were no longer using opioids or cocaine. And what I found was a very clear relationship of how long they could tolerate, keep their hand in the ice bath. And you can see the people who were in recovery, the ex-cocaine and ex-opioid addicts, were able to tolerate the pain for a longer period of time. They could keep their hand in the water longer than people who were actively using. And what was interesting to me is the people who were actively using opioids, many of these people on 70 to 100 milligrams of methadone a day, actively using opioids, were the least tolerant of this ice bath. And that kind of throws you in the face of what we think opioids do. You think that if you'd had 100 milligrams of methadone on board, you could hit me with the truck and I wouldn't feel it. And yet these people could not keep their hand in the ice water for as long as people who were no longer taking opioids. So a very counterintuitive sort of finding, and interesting to my clinical practice. So maybe that methadone patient lying in the hospital bed complaining of severe pain was in fact feeling severe pain. So what was going on here? I went back to the animal literature, and there's been this phenomenon that's been pretty well described in the animals for a long time, known as opioid-induced hyperalgesia. Hyperalgesia simply meaning that something that's normally a little bit painful is now extremely painful, hyperalgesic. And we know that in animal models, with animals that are pain-free, if you make them tolerant to morphine, put a pellet in under their skin or give them a self-administration paradigm where they're taking opioids on a regular basis, they become less tolerant of pain. So when you put them on a hot plate or you put their tails in hot water, they do not tolerate the pain as well as animals who are not exposed to opioids. So it appears that opioids, in addition to providing analgesia, also set into motion these anti-analgesic processes or hyperalgesic processes. And that when people are going through withdrawal and pain feels more sensitive to them during the withdrawal state, perhaps what we're simply seeing is an unmasking of this hyperalgesia. Now, why would this occur? The opioid-induced hyperalgesia is considered or has been conceptualized as an opponent process. So in other words, the hyperalgesia is a state, an allostatic state that occurs in response to the opioid-induced analgesia. So if you look at this schematic here, you can see that a patient's baseline pain tolerance may be right about here. We give them a strong opioid, and their pain tolerance improves, and it improves markedly. But as that increase in pain tolerance occurs, there's an opponent process that's kicked in, the opioid-induced hyperalgesia, which over time opposes that, and over time becomes the stronger of the two responses, so that patients are no longer getting analgesia from the opioid that's provided, but are now actually in an allostatic hyperalgesic state. And it's believed that this is functional, such that if you're walking around on 70 milligrams of methadone, that if you stub your toe, you can still feel pain. It's important that the organism can still perceive pain. So this may be the nervous system's response to opioid administration to ensure that pain systems are still active. And that's why we see hyperalgesia occurring. So the original study I had done looked at people who were all drug abusers, some clean, some in recovery, but what I wanted to do next was compare this to normal controls, and so these are data showing the similar sort of paradigm. Again, using the cold press or pain tolerance. This top graph up here is comparing patients on methadone maintenance in comparison to matched normal control patients. And you can see again on this simple cold press or pain tolerance test that methadone maintained patients can tolerate the ice bath only half as long as matched normal controls. And these are people matched on age, gender, and ethnicity. And I looked at it in another medication that we use to treat opioid addiction, buprenorphine. Some of you may have heard of that as Suboxone. It's another FDA-approved medicine to treat opioid addiction in addition to methadone. It's a partial agonist, a partial opioid agonist, unlike methadone, which is a full opioid agonist. But I found that regardless of which of these opioid agonists the patients were on, that again, they can only tolerate the ice bath for about half as long as matched normal controls. So clearly something going on in these people who suffered opioid addiction and were on opioids for the treatment of that addiction. Now, in kind of exploring this more, I realized that this was not a new observation, that actually back in the early 1900s, when we were starting to understand what opiate addiction was, that there were clinicians reporting these sorts of hyperalgesic responses. Clifford Albert said, at such times I have certainly felt it is a great responsibility to say that pain, which I know is an evil, is less injurious than morphia, which was the name for opiate addiction back then, morphia, which may be an evil. Here experience is needed. Does morphia tend to encourage the very pain it pretends to relieve? Charles Carter in the Journal of Inebriety, I'm never sure how to say that, inebriety. He is also affected by a hypersensitiveness to pain or a morbid intolerance of any kind of distress. He suffers. His suffering is actually great. To his astigmatic inner eye, it seems even greater than it is. So kind of this clinical understanding way back when we were starting to understand opiate addiction, that these people were more sensitive to painful stimuli. Taking some of this idea of opioid-induced hyperalgesia and moving from opiate-addicted populations to normal controls, we did another little study looking at people. These were healthy college students, healthy male college students. And we wanted to understand better how opioid-induced hyperalgesia may occur in normal control patients. And these were, again, healthy college males who had been exposed to an opiate at some point in their life, so they weren't opioid naive, but they were not opiate addicts or didn't use opioids on a regular basis. And we brought them into the hospital and we challenged them with either a dose of intramuscular morphine, IV morphine, IV hydromorphone, or placebo. So you can see that each of these days they came in and received a different drug. And then 5 to 15 minutes after receiving the drug, depending on the half-life of the drug, we gave them a shot of naloxone, or Narcan. That's that opiate antagonist, which blocks the opiate receptors and so immediately takes the opioids off the receptor. And you can see that in these normal healthy controls, that at 5 and 15 minutes after receiving the Narcan, their tolerance for pain decreased. So after a single dose of an opioid, and then giving that healthy normal control a dose of an opiate antagonist, I can precipitate hyperalgesia. So then these data suggest that it doesn't mean you need to be an opiate addict, it's simply opiate exposure that can result in opioid-induced hyperalgesic changes. Now, what are some of the mechanisms underlying this? There's a number of theorized physiologic or pathophysiologic mechanisms underlying the development of opioid-induced hyperalgesia. One of them has to do with the upregulation of excitatory amino acid receptors. We know that when an individual experiences pain, that an excitatory amino acid glutamate is released and it binds to the NMDA receptors on the peripheral neuron. We also know that if you give morphine, when it binds to the opiate receptor on these neurons, it upregulates a protein kinase, a second messenger within the neuron, that therefore upregulates the glutamate receptor. And so therefore, by giving morphine or an opioid, you can actually make pain systems, or you can make the nervous system more sensitive to pain by the upregulation of this receptor. And so one of the things that we did was in the clinical trial was to look at the effect of gabapentin, which is the inhibitory, kind of the opposite of glutamate, the inhibitory primary neurotransmitter in the brain. We gave gabapentin and showed that when we gave gabapentin to patients, who had who had opioid-induced hyperalgesia. These are patients on methadone who had opioid-induced hyperalgesia, that when we gave gabapentin, it essentially improved pain tolerance and pain threshold in patients both at trough methadone levels and peak methadone levels. So we gave a medication that increased inhibitory neurotransmission. It was able to kind of fight or block that excitatory neurotransmission that we theorized was underlying the hyperalgesia. And this was a 5-week randomized clinical trial of gabapentin, and the effects were noticed to be most robust in those patients on methadone who were doing well in treatment, so they weren't doing lots of other drugs on the outside. Now, another theorized mechanism for why people get hyperalgesic when opioids are provided is a mechanism that runs through the immune system, actually. We've known for a long time that immune cells, including glial cells, which are the immune cells of the central nervous system, have opiate receptors on them. We've never quite understood why immune cells have opiate receptors on them. Certainly that relates to some of the immunosuppression that we see in people who are doing opioids, but we do know that these immune cells have opioid receptors. When opioids bind to the opioid receptors of these glial cells, what we see is an increase in certain chemicals known as pro-inflammatory cytokines. So that when opioids bind to the nervous system immune cells, you see an increase in pro-inflammatory expression, pro-inflammatory activity. And that pro-inflammatory activity is believed to then feed back into the pain systems and upregulate the sensation of pain. So this theory portends a role for the immune system in increasing pain sensitivity or making people hyperalgesic. And so we looked at this with a different little study that we did looking at the effects of opioids on the inflammatory systems, and we looked at it in combination with pain. We've known for a long time that pain itself can be a pro-inflammatory process, that with the stress that goes along with the painful experience increases the expression of these pro-inflammatory cytokines. And if opioids also induce pro-inflammatory cytokines, what are we doing to patients when they've got pain and we're giving them opioids? Are we actually inducing a higher pro-inflammatory state because you're combining these two pro-inflammatory processes? And so what we did was we took patients and brought them again, on one visit they'd get an opioid, we'd look at their pro-inflammatory cytokines. The next visit they'd get just pain, again the cold pressor, and look to see what their responses were. And then we had visits where they came in and got the two together. What we found was when you compared the pain alone or opioid alone visits to the visit where they got both pain and opioids together, that there was a marked increase in pro-inflammatory activity when they got both together. So that by giving opioids to people who are in pain, you see an increased pro-inflammatory response. Now, that could be in some circles considered a negative thing, that pro-inflammatory processes we know underlie more and more chronic illnesses that we treat today, but it also, in pro-inflammatory processes, underlie the healing process. So it could be that by giving opioids in the presence of pain, we're actually inducing pro-inflammatory changes which are beneficial and improve the healing. But I want to take a step back because we've kind of assumed that this hyperalgesia we're seeing is opioid-induced hyperalgesia, when actually we know there are clear differences between all of us in this room with respect to how well we do on the cold pressor test. It's basically a bimodal distribution when you look at a normative population, that about 1/3 of people are pain intolerant on a cold pressor. So 1/3 of us in the room wouldn't be able to keep our hand in the water for longer than a minute. We'd be pulling it out. Whereas the other 2/3 of people can keep their hand in the water up to 5 minutes, up until the end of the test. So there's clearly a bimodal distribution in how people tolerate the cold pressor test. Could it be that people who end up on methadone and have drug addiction are actually the pain intolerant people, and that's why they look hyperalgesic to me when I test them? And there are data to support that interpretation. Animal data show that if you look at different strains of animals, that there are certain types, and I don't know these rats as well as some people in the room, but there are certain inbred strains that are very tolerant of pain. They don't have a difficulty tolerating their pain, and they get a great analgesic response when you give them an opioid. They get a lot of analgesia from an opioid administration. They also don't find opioids very rewarding. You kind of have to hide it in their food to really get them to abuse it. It's not something that they really necessarily enjoy. And those same strains of animals don't develop opioid-induced hyperalgesia to a great degree. You look at these other strains of animals and you see just the opposite, that these animals are pain intolerant by nature. They don't tolerate pain well. They don't get a lot of analgesia when you give them opioids, but they love opioids. They find them very reinforcing. And they also develop a lot of opioid-induced hyperalgesia. So could it be, when I'm looking at my methadone maintained patients, that I'm looking at humans that look more like these strains, that they don't tolerate pain well, but they get a lot of bang, they get a lot of euphoria out of opioids. And the data that kind of have looked at humans on opioids versus ex-addicts versus matched controls, trying to get a sense of, is this hyperalgesia opioid-induced or not, the data that are out there are essentially all correlational. That we've really just kind of compared groups of people on opioids to groups of people not on opioids, and we haven't necessarily determined whether or not the hyperalgesia that we're seeing is in fact opioid-induced. So that's some of the work that we're doing currently. Because we can't ethically take people who have never been on opioids and start putting them on opioids to see if their pain gets worse, right? The tack that we're taking is going the other way around, that we're looking at patients who are already on opioids, and as they taper off of their opioids, does their pain improve? So these are studies that we're currently doing. We're looking at it, first of all, in groups of patients who have opiate addiction and are coming into treatment and are being tapered off or detoxified off of their opioids. And we're comparing not only their cold pressor, but we've added another pain assay to our battery known as quantitative sensory testing. So we're looking at pain in a second way. And so we're looking at people who have been abusing prescription opioids entering buprenorphine or Suboxone treatment. So half of them are going through the detox and half of them are going to be on kind of a maintenance dose, and we're going to compare those groups over time to see, does their pain improve, the patients who are on detoxification? If opioid-induced hyperalgesia in fact exists, their pain should improve as we pull the opioids away from them. Even more important clinically, though, we know that we've got lots and lots of chronic pain patients out there who are on opioids. It's been estimated between 5 to 8 million Americans have chronic pain and are taking opioids on a daily basis. We have concerns about that. And so there's actually the CDC guidelines that came out last year talk about the need to perhaps taper some of these patients off of their opioids, that they might do better off of their opioids. And so that's a small study that we're just starting right now, looking at the same thing. As chronic pain patients are tapered off of their opioids, does their pain improve? Could it be that we've been treating chronic pain patients with opioids and actually contributing to their pain experience? We don't know that. So that by looking at chronic pain patients as they're tapered down off of their opioid prescriptions, will we see improvements in their pain? And then a final area that we're just starting to look at, there's been some literature that's been emerging to suggest that opioid-induced hyperalgesia occurs in the surgical setting, such that when you go in for surgery, when you're under the knife, so to speak, you're also receiving large doses of opioids. And when you come out from surgery, you're going to be receiving opioids for the treatment of that pain. Could the opioids that you're receiving intraoperatively and postoperatively be contributing to the postoperative pain that you feel? Are we inducing opioid-induced hyperalgesia in patients that we bring in for surgery? And so we're doing some work with clinicians at Georgetown and hopefully here as well, looking at opioid-sparing or opioid-free surgery. It's possible to do surgery without the use of opioids. And it appears that patients who are going through these opioid-sparing surgeries don't have as much postoperative pain. So to what degree is postoperative pain an expression of opioid-induced hyperalgesia that's due to the opioids that are given intraoperatively? So that's what we're looking at next. And there's also some evidence to suggest that the amount of opioids that you receive intraoperatively may predict who continues to have pain after surgery. It's been estimated about 10% of patients who undergo a surgical procedure will still have some pain a year out. Could that be related to the opioids that they receive intraoperatively? So that's where we're going with this now. So who cares? I think we all need to care, and one of the things that we're all really caring about it because of is this prescription opioid crisis. We know that the number of drug overdoses in this country has far surpassed people who die from car accidents, gun injuries, or HIV, and so therefore the prescription of opioids, the fact that opioids are out there all over the place right now and very prevalent in our community, means that we all need to be caring and thoughtful about how opioids are prescribed for the management of pain. Thank you.
but all of our scientists will be out in the atrium afterwards.
And, oh, yes.
I might be able to speak loud enough. Can you hear me?
I can hear you.
I was just curious, when someone comes in to see you and they're complaining about pain and they're already on opioids, wouldn't the first thought come to mind was to clear them of all the opioids to make sure? I'm a recovering addict. I used opioids for 17 years. Okay, I'm coming up on 2 years clean.
Excellent.
I'm on no maintenance. I'm on no maintenance programs. I was, however, like 10 years ago, introduced to all the things that you're talking about, except the naltrexone, because that was, or the Suboxone, because that was only recently put out. I see that being more destructive than the opiates, okay, in the addict community. I was just wondering, like, why don't you just go about it? If someone comes to you complaining about pain that's on opioid, if your test's shown there in your little bar graphs, people that are off of it or ex-addicts that are now clean have a better tolerance, why wouldn't your first plan of action be to detox them off of the opiates
It's a
altogether?
great question. I get it all the time. The reason that I don't is because many patients with chronic pain on opioids do very well and never develop any indicators of addiction. That it looks like about only 8% of patients who have chronic pain and are given opioids ever develop an opioid use disorder, and 8% is about the same as anybody in this room. So the chronic pain patients aren't at greater risk. So I have concerns about taking opioids away from people who are doing well on them. So I'm not saying opioid-induced hyperalgesia isn't an issue, but I also am concerned about throwing the baby out with the bathwater, because we have a lot of chronic pain patients who do well on their opioids, never develop addiction, and so therefore kind of this idea that we should take opioids away from all pain patients, I have concerns about.
Okay. I
Yeah.
appreciate it.
No, it's a great question, though. I get it all the time.
Like I said, I've been involved, like I've seen it, those pictures in Kensington and all that. I know where they're at. I know people that suffer to this day. My heart's actually racing because when I hear stuff about that, about pushing methadone, about naltrexone, about keeping people on opiates from pain management, I can only go off from my experience and what I experienced. I have no research to back this up, only from what my eyes have seen and the behaviors I've witnessed. I've never seen any benefit or anything good come out of that, because the ones that were claiming the good is done are the same, and I hate to sound cynical, are the same people that you'll see on the streets later on that night, you know, doing their thing. And, you know, I've known people, and being clean for now, coming up on 2 years, people talk about this stuff once they get clean, about how the manipulation tactics and all that, and it's just, to me, it's like, eliminate it.
Well, and one really good point that you're kind of bringing up for me is the fact that we also understand that opioids are not the best treatment for chronic pain. That the things to really treat chronic pain include exercise, weight loss, mindful meditation, acupuncture. Opioids are part of the process, but we've, since the 1990s, really focused on opioids as the thing to give people with chronic pain, and because of that, we haven't looked at some of these alternate sorts of therapies that can be very, very effective. So we have over-relied, I would say, on opioids. We need more thoughtful about the prescription
One more thing,
of
and then
them.
I'll be done. I had a surgery in February 14th, believe it or not, Valentine's Day. My girlfriend right next to me, God bless her, she's not an addict, but they prescribed me opiates. First thing they did, 90 oxycodones, right? I told all three of my surgeons that I'm an ex-addict, that I've been clean at the time for almost a year. Okay, this was back in February. They still gave me the medication.
I know.
I walked out of the hospital, I gave it to her.
Good.
She threw it away.
Right.
I was in pain I had sinus surgery. It was a 6-hour procedure at Jefferson. They gave me the medication. I didn't use it. And I got through. I was in pain for 8 to 12 hours. It's normal. But I'm just saying that people that are actively using or people that are on opioids tend to manipulate reality. Because I've done it myself.
It's part
It's
of
just something
the
to take into
disease.
consideration.
Absolutely.
Because the other
It's part-
stuff that you're doing is just...
Right. and that's part of the disease. And I'll just say one last thing, is that the work that we're doing at Georgetown, looking at opioid-sparing strategies, is exactly for the kind of patient population you're describing to me. People who are in recovery, who don't want to be re-exposed to opioids. How do we manage their pain? And so the studies we're doing are looking at patients who don't want to be re-exposed to opioids. Can we do surgery without opioids and not have to re-expose them? Because the pain can be managed in many other ways. So thank you for that. Thank you.
Thank you, Dr. Compton, and thank you all so much for coming to the Penn Neuroscience Public Lecture Series. Our scientists will be out in the atrium along with a bunch of refreshments for any other questions that you may have.